أعزاء طلابي my seniors and my junior colleagues. شكرا لدكتور رافد اللي سمح لنا أن نجي ونقدم محاضرة أو تقديم في موضوع معين. طبعا بالنسبة لي يعني بعد أن أعرف من الحضور متأكدة أنه عندكم من العلم ربما بقدر كبير وربما أكثر، بس it's a good opportunity to meet you all. فإحنا اليوم راح نحاول شوية غيرنا بالpresentation. Meant to be 3 cases, but we are going to present only 2 cases because the time may not allow us to present the 3 of them. Recently, and I'm sure we all know now, that we are adopting a program to get some students from Iraqi medical schools to come and test the way the NHS works and our duties in this NHS service. So we've been very lucky to liaise with the Bristol University Medical School, and we managed to arrange for some of the medical schools from Iraq, everywhere in Iraq, from year 4 and year 5 to come and for 1 month during the summer holiday to participate in, with us as a clinical attachment. Luckily this year, after failing last year because of the visa issues, we managed to get 3 or 4 candidates from year 4 and 5 went to Bristol, and I was so lucky to have 3 of them with me in Yeovil. Each one of them spent 1 month under my guide and my colleagues, and we were very pleased to know that their standards were very amazing. Their language, speaking and writing were excellent, and their skills in computer and IT was amazing. And the knowledge, I cannot say more. Some of them know more than what I knew. And one of them actually tried to show me how to interpret ECG in a better way, and he was only year 4. So I am very, I don't feel I am annoyed if someone tells me this is the way, because I felt that even after many years of being a doctor, every day I am learning from everyone, including the very young doctors and students. So being a doctor is a continuous process of learning. So for today, the first case, I don't want to waste a lot of time talking. I asked my colleague, who is a graduate from Baghdad University this year. He has not been registered yet. He is one of the 3 people who came to be with me in Yeovil. His name is Dr. Nasim Wajdi. He's medical school graduate, and he's going to do the presentation. I really appreciate his skill of putting what I write, which I write very nicely, but I cannot use this effectively. They put all the information on the slides, and not only that, after visiting Suleymania recently, I have found many people and many students or doctors, newly graduate, are so skilled in all aspects, and I've been using them. And one of them is Dr. Omnia. Dr. Omnia Rafid, she is another this year graduate who is excellent by all aspects. And being a female doctor, I encourage all females to be doctors and to be as effective as everyone here. And this Dr. Omnia and her colleagues made me very proud of them and of myself, that there are people who are going to lead the future in Iraq. So welcome Dr. Nasim. He will do the presentation. I will add a few things. The first case, which I am, so let me just is the hospital I work in, Yeovil District Hospital. It is a district hospital in a small town, and we belong to a tertiary university and center, which is a Bristol University. And it's in Somerset. It's about 2.5 hours southwest London. Let me just see that is the other presentation. This is the other presentation. Okay, fine, I don't mind. So, the first case we will present, this is one of my IMT doctors who seen this case. This is Dr. Wajdi. So we will start with this case, so quickly we will finish with this one because it is of interest, and then Nassim will do the second presentation, which will be probably of different case scenario. So the reason I brought this case is because of interest. This gentleman, young gentleman, came to the IMT because of 2 weeks history of reduced appetite with vomiting, and the GP started him on I think this is not the way he started. Not the way the slides are arranged, because we ended up, I know that it is not the beginning. I apologize. Let me just carry on. Anyway, this gentleman has persisted. He's only 18 and he came with reduced appetite and vomiting. Of course, the GP has given him omeprazole. And then he came to the A&E because of sudden onset of chest pain, breathlessness, and the vomiting started to settle. His background is autism, and normally he can communicate verbally, and he lives independently. When examined, he had news. What is the news is the new like early warning symptoms. So he was like fine, except his potassium was on the low side, and he had slightly or mild liver function test there. This is his chest X-ray. I am sure everyone will spot what is this. Just lift your arm if you think you know. It's easy, isn't it? Huh? Yeah, subcutaneous emphysema, which means that he had probably ruptured one of the alveoli and ended with mediastinal pneumothorax. This is the CT scan showing that there is air surrounding the whole heart and extending to the soft tissue. If I return back to this X-ray, you can see is there any arrow in this one too? Oh yeah, so you can see the subcutaneous emphysema here. You can see all the and you can see this line here, which is going up to here. And this is what we call Hamann sign, where there is air tracking up to the neck. And it is confirmed by CT scan. So what we do in these cases, most of the time, this Hammond syndrome is idiopathic. It leads to rupture. One of the alveoli rupture, and it leads to this one. It's a self-limiting. And the most important thing we do is to rule out iatrogenic causes like a trauma or sometimes rupture esophagus. That's where they come with vomiting. So this patient, because it was so scary to see him, and he was very short of breath, and he was very emphysema, surgical emphysema, he was referred to Bristol Royal Infirmary for further assessment. When he went there, he was offered an OGD, and the OGD did not show any rupture or anything, but it showed that he has inflammation. So he was given proton pump inhibitor, like omeprazole, and let him go, and the GP to follow him. So this is what is Hammond syndrome. It is a rare. Usually is not preceded by any thoracic trauma or surgery, and it is more common in males, and it is due to increased intrathoracic pressure causing damage to the alveoli. The risk factors for this is being a smoker, or if they are asthmatic, or if they have interstitial lung disease or other respiratory infection. The precipitating factors are cough, vomiting, Valsalva, squatting, constipation, straining, weightlifting. All these can lead to alveoli rupture. So the patient comes with retrosternal pain, neck pain, and swelling, breathlessness, dysphagia, many other symptoms. And the signs we see is the crepitations in the soft tissue, subcutaneous emphysema. Hammond signs is we hear especially clicks and extra sounds when we listen to the chest. It's called Hammond sign, and the patient may come with mild pyrexia. How would we investigate? Chest X-ray is very important to show that. And the CT scan with contrast will confirm the subcutaneous emphysema, and the treatment is conservative with observation and assurance and oxygen. So this patient was assured and sent home. Then 2 weeks later, he went to the GP because his mother was very concerned about him. He became dizzy, he had double vision, and the eyes were crossed, and he was confused, and he had many other symptoms, and the GP thought probably this is omeprazole-induced symptoms, so he changed the omeprazole to another form of PPI. On examination, he was referred to the hospital. On examination, the patient was very drowsy, and his Glasgow Coma scale was very depressed. So he was rousable to voice. He was just answering yes and no. He had very typical vertical nystagmus. He was ataxic on gait, and the power and the sensation were intact. Visual fields were fine. So at this stage, do you think of any diagnosis? The patient has nystagmus, he is confused, and he has ataxia with some visual, visual field intact. Any idea in someone who is young, male, been vomiting, he's autistic? Maybe you don't think of it, but this is typical clinical signs in support of Wernicke's encephalopathy. So he came, chest X-ray, we thought probably he had another mediastinal pneumothorax, but the chest X-ray is completely normal. We did the brain scan on him, And the brain scan, I don't know the details of the brain scan, how to interpret, but apparently it is very typical in support of Wernicke's encephalopathy, where there is inflammation and the swelling in the thalamus and the hypothalamus area, where the exact pathology is. So, as we know, Wernicke's encephalopathy usually happens in those who are, most of the time, either alcoholic, who abuse alcohol, and they are deficient in vitamin B1, which is thiamine. So, it is acute thiamine deficiency in susceptible host, and the patient usually, as I said, alcoholic, but in this case he was not alcoholic, but he has some behavior and dietary problem, and he forced himself to vomit every now and then, so his diet was not the best. And on testing his blood, he was confirmed that he is deficient in thiamine. So it is uncommon condition, and this is the classic triad, which is mental status change, ophthalmoplegia, which is the nystagmus, and the ataxic later. And the cause in this case is very dietary. And this is, of course, the sources of vitamin B1. Now, if we don't treat this patient or patients like him immediately, they will end with permanent damage and they may end with death. So it is very vital to start them on thiamine ASAP. And this is, of course, the advice later on what to have. But the common risk factors in these people who may have thiamine deficiency is alcohol dependence. That's why people who, when they come and we know that they are alcohol dependent, we should always start them on multivitamins and thiamine to prevent this serious pathology. And it happens in those who are with AIDS or chemotherapy with cancer, and in this category, this patient is malnutrition because of his autistic behavior. We need to skip, we don't need it. So that's what we did the investigation for someone who come with these symptoms. It is very emergency treatment, and we have to treat quickly before they end with permanent damage, and they end with maybe even Korsakoff psychosis or even dementia. And I'm talking about the most severe one, especially the alcoholic people. So the diagnosis is blood test, which will confirm thiamine deficiency, MRI scan, and lumbar puncture will be normal. Treatments is thiamine, magnesium, folic acid is supported. So back to this case, the patient improved significantly after a few hours from starting him on the vitamins. The neurologist was involved, and he recommended that we give the vitamins for 10 days, and the patient was switched to oral, and he was fine with the dietitian advice afterwards. So this is the first case. I think it is very